move from this rather sophisticated arena of major surgery, saving life, changing heart, down to the dollar sign. And this is my dollar. It's my very own dollar. And I think that you recognize that most hospital environments are struggling with some form of economical issues. I also think it's quite obvious that the main part of economy is related to personnel. In Stockholm, we have a complete disaster right now because of the nurse situation and the nurse trade union and the nurse salaries. At least in my home hospital, we are closing down some 2.5 general wards, depending on problems with nurses. We have facilities. We need to have some theaters, and if someone of you have the time, please go up and look at the new Karolinska Hospital. It's just building it up, and it looks quite expensive. And then we have the equipment that we are discussing today, and when we have the equipment, we usually have some 5 to 10 years payoff time. Someone has to clean things, we have to have service and maintenance, and then we have the drugs. And I was rather happy this morning when I had my morning newspaper, because on the first page, in my paper at least, was the concern from the Stockholm County about the cost for cancer therapy. And I think it's no doubt that our anesthetics are relatively cheap, but nonetheless the pharmacy budgets are also a concern for the healthcare environment. Disposables as well, and you can go down to the exhibition and find thousands of disposables. I'm going to address a little bit about cost-benefit, and that's not really the truth perhaps, because I will more address something that we call cost minimization. I expect my patients to be well anesthetized and to recover acceptably, but I would like to look at the lowest ever cost. And I think this is in line with lean production, minimizing waste. Waste of money, waste of time, waste of resources in general. And again, I think that we as anesthesiology departments, we are a service activity. It's hard for me to set up my own practice in the garage. Come and sleep Jakobsson's sevoflurane anesthesia. It wouldn't really pay, I think. So we have to have the personnel around, we have to have the equipment and the facilities, and then we have to choose the drugs and how to use them. And if we use them efficiently, we can have a high patient turnover, and we can have a lean production, and hopefully we can have satisfied patients, but also of huge importance, hopefully satisfied surgeons, because I think this is a teamwork. Okay, disposables, you recognize the things. We usually need to have an IV, we used to have a laryngeal mask or a tube. We need to have some fluids from Baxter eventually, and we use some induction agents, and then we have some analgesics and anesthetics, and I'm going to focus on the anesthetic part. We need to start up, we need to think about maintenance and emergence, and altogether we have to think about the turnover time in a theater. And to me, theater time is the expensive time. So the more efficient I can do it, the more efficient time that I can spend in the theater, the more lean I would say we are. So I'm looking at the peri-anesthesia turnover time. The time that we occupy the theater before start of surgery, the time we occupy the theater at end of surgery, is all included together. And I think you recognize these molecules, perhaps not by the generic formula, but at least at their names. Sevoflurane, used commonly. Desflurane, used rather commonly. Propofol, absolutely the drug of choice for induction, and also for some rock singers I have heard about. Nitrous oxide, we have to keep it in mind. I know that the Enigma 2 study turned out negative, meaning that they didn't see any adverse effects from the nitrous oxide maintenance use. which I think is reassuring. This molecule has been around for quite some years, and it may have a place in also modern anesthesia. We have the xenon. It came and it came, and we really don't know exactly where it stands today. Now, let's see, what do we know about the inhaled anesthetics and the anesthetics in general? And I think it's no doubt, if we look at the evidence base, and I think we'll believe in the meta-analysis, and if the meta-analysis turn out, well, one way or another, we believe that that is some form of evidence-based medicine. And I think there are so many papers, both in anesthesia and analgesia and anesthesiologists and in Canadian Journal of Anesthesia and so forth, stating that if you look at emergence, the time patient needs to recover from anesthesia, it's no doubt that the third generation of inhaled anesthetics comes out the best, and eventually even that Desflurane is slightly faster than sevoflurane. Right, so we need to have safe and effective things. It should be easy and simple to implement, as we heard from the previous speech. And it should be suitable for the majority of patients and procedure, also in line with the previous speech. We should be able to use it for the big and the small and for the young and the old. And it all comes down to quality assurance and lean production. I like high volumes. We are in Sweden talking about high facility centers, and it may not turn out that we need to go to Scandinavian high facility centers because we don't do enough many of heart-lung transplants, so they may need that we cross the Öresund to cooperate with Copenhagen, for instance. And we all look for lowest loss and minimal waste. What do we know? Regional versus general, inhaled versus intravenous, pro-con debates is all over the place. And some of us prefer the combined techniques. Costs is always an issue because we usually buy anesthetic drugs on tenders. So my price are probably not the same as your price. So you have to compare your own cost effectiveness from your prices. I've been a little bit of crazy. I've tried to keep all the things the same way, and then we have just chosen different main anesthetic techniques. So this was a study that we set up with 75 patients doing exactly the same procedure, not the same patient, but they had a different patient doing exactly the same procedure. It was even the same surgeon. And we randomized them to propofol, fentanyl, sevoflurane, nitrous oxide, propofol, remifentanil. And we looked at all the things, and it came out rather much the same, rather minor day surgery. But when we came to costs, and I calculated all the costs, direct costs associated to the drugs, the inhaled anesthetic technique was much cheaper. All other outcomes were the same. And even if I counted the wastage, and with or without wastage, it always came out cheaper. Now, part of that is how do we choose the fresh gas flow? Should it be 0.3? Should it be 0.8? Should we include nitrous oxide? And of course, there are the direct costs, and then we have to consider outcome. Do high FiO2 interfere or changes the risk for surgical site infection? Some beliefs, and there are even meta-analysis suggesting that, for instance, for the major colonic surgery, one should use the high FiO2. The Lars Rasmussen group came out with a paper just in the last British Journal of Anesthesia May issue, suggesting that it may have impact on the cancer reoccurrence. The all-Apfel and Kari-Kortela study, again looking at anesthesia and the risk of PUNV. And the only thing that slide says to me is that I can never guarantee a patient not to vomit. Whatever I do, we will have a residual patient population of approximately some 20% that may get nauseated even if we give triple prophylaxis. So we continue doing the same thing again. Another group of patients, and now the only thing that we did, we were adding or withdrawing nitrous oxide. And again, it was all the same, but now when we use nitrous oxide, we reduce the direct cost. So this is again a cost minimization study. It's not a cost efficacy study. The patient slept and they awakened exactly the same time. They were discharged exactly the same time. There were no hospital admission, but we had a lower cost. So we continued. I love money. So now we randomize patients to 3 liters with oxygen air, 2 liters oxygen air, 1 liter oxygen air, and 1 liter oxygen and 2 liters of nitrous oxide. Again, looking at costs. And the interesting thing is that when we looked at it all, it came out that the oxygen and nitrous oxide was the cheapest. So we continued match racing. This is pure match racing. Now we have a group of Propofol, Desflurane, sevoflurane. Again, minor ambulatory surgery, but it's in line with the meta-analysis. It comes out about the same, but emergence faster, slightly slower, slowest. Discharge times, the same. But when we measure the cost, it turns out, which is interesting, that obviously has sevoflurane and desflurane looked at each other pricing, because the prices came out identical, but almost half of that over Propofol Tci. Now, can we do other things to reduce cost and perhaps facilitate emergence? The EEG-based things. This is a Desflurane study. This is major spine surgery. And what we can see is also in line with what has been shown in meta-analysis, that the emergence time was shorter when you had an AEP, the time to orientation slightly shorter, the time and PACU the same, but the cost was reduced. We could fine-tune the anesthesia delivery and manage. Are there other benefits of having, for instance, an AAI or a BIS monitor? Yeah, there are papers suggesting that the risk for cognitive impairment and the neuroinflammation changes. And I would like to share this paper rather recently published, where they looked at some 1,700 more than 60 years of age patients randomized to BIS or non-BIS group. And it again turned out rather nice because emergence was faster, hospital discharge was faster, and most important, there were less delirium and less early cognitive disturbance and less long-term neurocognitive disturbances in the group receiving BIS-titrated anesthesia. Now, I know that Professor Avidan is here in this meeting today discussing, and their paper seemed to turn out that it was better if you had a goal to minimize the risk for awareness, to rely on the minimal alveolar concentration. So my suggestion would be that we combine an EEG-based technique and a MAC end-tidal concentration in order to minimize the risk for awareness, optimize cardiovascular stability, improve rapid recovery, reduce anesthetic consumption because I like the less dollar, reduce the risk for PNV in line with the Enigma 1 study, and reduce the risk for neurocognitive side effects. So low flow anesthesia, going down less to 1 or less than 1 liter, has physiological effects and has potential other effects as we decrease the consumption of inhaled anesthetics, thus economical effects and ecological effects, right? So we have to have certain things going on. We have to measure FiO2, we have to measure SpO2, we have to measure end-tidal carbon dioxide, and we have to measure end-tidal anesthetic gas consumption because it changes things. I have an old circle. This is not a flow eye. I just wanted to stress once again, going down to low flow anesthesia, we have to have certain safety and we have to have certain carbon dioxide removal somehow. And we have to know that the dial concentration will be higher than the inspired concentration, that will be higher than the inhaled end-tidal concentration. Now, Professor Ed Eager, already a long time ago, suggested that low flow anesthesia should be cost minimization efforts. So we did the things. We took patients again, same surgeon, same procedure, and we changed the fresh gas flow. And again, you can see that when we go from 6 liters to 3 liters to 1.5 liters, so half the volume at each time, we can see that we reduce cost rather dramatically from 150 to 57 to 27. Outcome was definitely all the same. All patients slept, all patients recovered, all patients were discharged exactly at the same time without any whatsoever differences. So we continued and went further down, and we want to go down to at least what we consider more or less minimal flow. So we looked at a 0.3 liter per minute fresh gas flow. And we found exactly the same thing, that the gas consumption decreased with a benefit. The other thing that we recognized, that we had a stepwise increase in dial anesthetic setting, but a decreased consumption. So although the vaporizers showed high values, the consumption was low and obviously beneficial. Manual versus ET control, and I have not tried the flow eye control, and I'm very, very thrilled in doing that. We used one of the other machines that had a Untitled control thing. And when we compared 200 mils, 500 mils with Untitled control, we ended up, again, in a prospective randomized single-blind study, measuring the vaporizer before in each procedure on a precise scale. We found 0.11, 0.14, in line with all our previous results, and an 0.15 for that machine's Untitled control. And I'm looking very much forward to look at the flow eye. Other people have found slightly different results, and I will hasten now to my next study, just in between saying that it's not only me. There are also several other authors and researchers that have found that intravenous techniques always are having higher direct cost. So what did we do next? You may say that we are insane, and I can agree on that to some extent, but we tried to standardize everything. The thing that we did is that we fixed the fresh gas flow, and we fixed the main anesthetics. So the model looks like the following. We looked at the wash-in to 1 Mac, and we looked at the wash-in between 1 and 1.5 Mac. Then we went back to the Avidan 0.8 Mac during anesthesia. Then we closed the vaporizer and looked at extubation time, eye opening time, and again we looked at the amount of gas consumed. Now we have 4 groups. We have a Desflurane group, we have a sevoflurane group, we have a 1 liter flow rate, and we have a 0.5 liter flow rate group. And we can see that the amount of gas consumed decreased rather dramatically again. And the decrease was highest for sevoflurane. And if we look at time reaching the 1 Mac, you can see that if you do this rather stupid technique, no wash-in thing, you put the fresh gas flow on the 1 or 0.5 liters per minute directly, we could reach a 1 Mac for Desflurane at 3.7 minutes, and that at least much, much faster than the scrub nurse dressed the patients in our institutions. And you can see that we reach even with also with sevoflurane, this within 6 minutes, and that's, at least in my institution, more than fair enough for having the patient dressed. Now we did the next maturation. So we took the technique that we have used before, and we are looking at the flow eye. Exactly the same model. So far we have only pilot patients to present, but it looks quite nice. It's again the same group of similar procedures. And what do we see? We see that the time to reach 1 Mac is identical with the retrospective controls. We see that time to reach 1.5 Mac is identical. But we see that the consumption of inhaled anesthetic is even lower for the flow eye, making it even more effective in terms of cost. And when we compare our patient data with the lab tests from Maquet, we actually see identical consumptions. So I'm rather happy that we can show that their test information is actually accurate in the patients. Is this really worthwhile? I think it is, because you have to multiply this consumption with the number of minutes that you anesthetize people in your hospital. And I also would like to address this very recent review paper from Anesthesia, which again says that it is worth considering also anesthetic cost because it has a bearing on your department. So trying to summarize, it's no doubt that the inhalational cost is associated with lower cost than TIVA. Low fresh gas flow reduces costs, quite natural, and it has an environmental saving effect. I'm going to bike home from this meeting. I'm very happy to have a fresh, nice gas in Stockholm, air in Stockholm. Sevoflurane actually reduces direct costs slightly more than Desflurane, but it does both reduce the amount consumed when we go down to low-flow anesthesia. Desflurane has a slightly more rapid wash in and slightly more rapid wash out. The new flow-eye concept seems without doubt to further reduce anesthesia gas consumption, saving money and saving the Swedish Stockholm air for us bicyclists. Thank you very much for your attention.